Good morning, everyone. My name is Dr. Stanley Jordan from Cedars-Sinai Medical Center in Los Angeles. I'm very honored today to be speaking with you, at least virtually, for the MATH 22 conference. Today we're going to talk about therapeutic approaches to management of antibody-mediated rejection. These are my disclosures. First, I want to talk about the antibody theory of transplant rejection, going back to the very beginning of this issue, and talk about how the old becomes new again. From my viewpoint, it really all started with this paper in 1969 from Dr. Paul Terasaki, who really opened the door to the antibody theory of transplant rejection. His paper, entitled Significance of the Positive Cross-Match Test in Kidney Transplantation, revealed that antibodies were playing a very important role in causing graft loss. Now, what this led to, of course, was the development of a screening mechanism, the cross-match test, and the various derivatives of that, which are more of a just say no assessment of antibodies so that we could not transplant these patients. So we created a large cadre of patients who were sensitized and really were not able to achieve life-saving benefits of transplantation. So where are we now? Well, alloantibodies are still a persistent and often impenetrable barrier to transplantation. Allosensitization to HLA antigens represents one of the most difficult and as yet unsolved problems in transplant medicine. And we know there are multiple pathways to injury, and this would include donor-specific antibodies that we can now identify that have the capacity to injure or allografts directly through CDC or complement-dependent cytotoxicity, and or ADCC, antibody-dependent cellular cytotoxicity. Desensitization therapies have emerged to treat highly sensitized patients or to remove or deplete alloantibodies, but really nothing has been able to address all facets of the sensitization response or completely remove antibodies for long periods of time in these patients. So today, our focus will be primarily on chronic antibody rejection. And we know this is a formidable opponent, and there are no proven therapies. And this paper we did with Dr. Mark Haas a few years ago looked at differences in survival between patients who have pre-existing DSAs type 1, these are highly sensitized patients who have positive cross-matches at transplant, or those with antibody rejection type 2, where we have de novo DSAs and transplant glomerulopathy. Obviously, or maybe not so obvious, you can see that people who have pre-existing DSAs do much better over time because our therapies with IVIG retux, plasma exchange work pretty well to get after these. But patients who have chronic antibody rejection do very poorly over time, and really there's nothing that we have for them at this point. And what we saw also is very important and telling in this assessment that when we looked at the ability of our therapies to reduce antibody or change the relative intensity score of DSAs, if we got a reduction, patients had much better outcomes. If we were unable to reduce antibody, these patients did much worse and lost their grafts at a high rate. So CMR treatment, if you don't have reduction of antibody, you have a poor outcome. We know that chronic antibody rejection is now the main cause for graft failure around the world. Here, a graph showing the rates of graft failure in France by disease, 40%, or antibody rejection, US about 50%. So it's a big problem. Now, people, we've really tried to address this, and this was a paper from a Congress that was gathered here in Los Angeles a few years ago. Carrie Shenstock wrote this paper, and we looked at almost every paper available on antibody rejection, chronic antibody rejection. And this consensus group came up with a statement, and I want to read it to you. It says, while it was agreed that the aims of treatment are to prevent renal or preserve renal function, reduce histologic injury, and reduce donor-specific antibody, there was no conclusive evidence to support any specific therapy. As a result, current treatments recommendations are largely dependent on expert opinion, It is acknowledged that properly conducted and powered clinical trials of biologically possible agents are urgently needed to improve patient outcomes. So where do we go from here? Well, I think that we, at that time, were beginning to see some breakthroughs, and they were not evident at the time of that meeting, but we are turning the corner. And one of the first studies that was done and published a few years ago was this one looking at a new anti-CD20, obinutuzumab. This drug has been a blockbuster in lupus and other autoimmune diseases, but unfortunately it failed to show reduction in DSAs to a meaningful degree in highly sensitized patients. So it's a bit disappointing for us, but this is why we do these trials. And I think that it is still useful in treating antibody rejection in patients because it is much more durable and intense than rituximab. So it may still have a role in transplant medicine. I think the biggest breakthrough from my standpoint is this drug that we started working with back in about 2014. We published this paper, it's now sort of old news, in 2017, where we showed that there was a virulence factor isolated from strep pyogenes called IGUS, or immunoglobulin degrading enzyme of strep pyogenes, now called imlifidase, is able to rapidly cleave and disarm antibodies, IgG antibodies in the plasma of patients. So the raison d'etre for this is for this bacteria to defeat the human immune system by disarming IgG antibodies and basically cutting off CDC and ADCC. Well, this enzyme was sort of harnessed to attack the problem of desensitization. And this is the first patient that was treated on dialysis with imlifidase, 30-minute infusion. You can see within 6 hours, basically all the HLA specificities here in red, there are 97 of them, are gone. Or the blue ones that are retained, we think, are these single-cleaved molecules. More importantly, looking at C1q, after 1 hour, they're all gone. So this suggests you can get rid of these antibodies very quickly. This may have applications in patients like heart and lung transplant patients where you can't wait long periods of time to desensitize them. So we'll see. Another important observation here is that it does really matter how you treat these patients coming in. So we think that what we found is that we desensitize them with immunoglobulin and rituximab beforehand, and then afterwards gave them this again, that we had much better outcomes in our cohort, our colleagues from Switzerland, or Sweden, where no desensitization was given and no IPIG or retux given post-transplant. So you can see here, the bottom right, that pre-desensitization MFI scores 6 hours after treatment and then 1 month. They're actually rebounded pretty quickly here. We're associated with more severe antibody rejection episodes. At the Cedars, with our protocol up here, you can see that at 6 hours it was all gone, but at 1 month still pretty much gone, and that we did see some rebound around 3 months. So this treatment does help prevent rebound. Okay, so let's move on to another interesting cytokine that we think will be useful, or useful for targeting in terms of treating antibody rejection. This is interleukin-6. And this is Tanemitsu Kishimoto, a very interesting guy. He discovered IL-6 back in the late 80s. And I actually wrote him a letter around 2005, I think, asking him for a mouse antibody that was, at that time, a rat anti-mouse IL-6 receptor. He was very kind and compliant and provided to us, which started our interest in looking at IL-6 modification in kidney transplant recipients. And it first started with this study in mice where we used an HLA-A2 transgenic mice. Skin grafts were put on C57 black 6. And what I want to show you here is over on the right side here is that when we isolated plasma cells from the bone marrow of these mice that had no treatment, you can see that by Luminex type assay that we could detect anti-HLA-A2 antibodies from these cells in the supernatant in animals receiving treatment with anti-IL-6 receptor, and this was at this time a human or mousinized anti-IL-6 we got in about 2012. And then, more importantly, if we took these cells and added anti-IL-6 receptor, then we could inhibit plasma cell IgG production to HLA-A2, even after it had been established. We also found that in these mice, that T follicular cells and Th17 cells increased, were reduced with anti-IL-6 therapy, and Tregs were increased with anti-IL-6 receptor therapy. We subsequently looked at patients on dialysis, and I think this is a very important area to look at too and study, and it is being studied now, and we can talk about that at the end. But patients on dialysis, highly sensitized patients, tend to have log increases in IL-6 levels, C-reactive protein, which is the induced ligand of IL-6, and concomitant decreases in counter-regulatory cytokine TGF-beta. We also saw that there was upregulation of IL-6 in the serum of patients with multiple types of injury, including ATN. So it is not specific for antibody rejection, but it does show injury to the graft. This is a paper by Van Loon et al. Recently published showing that IL-6 is one of the most important cytokines in differentiating ABMR from no ABMR in 293 patients that they looked at. And I think this was a 28 cytokine panel, so it is important. More importantly, I think here, and this really was revealing to us that in this study, Jordan Hober and his colleagues were able to show, using a humanized mouse model, putting a human coronary artery into these mice and reinstantiating them with a human alloreactive T cells, that these coronary arteries would develop animal proliferation and the endothelial activation. And part of this endothelial activation you can see here is a lot of IL-6 production by the endothelial cells. This suggests that that what is happening here is that the IL-6 is being upregulated by antibody binding or by immune activation and further activates immune responses. Importantly, this was reduced when anti-IL-6 therapy was used to treat these animals, and it was associated with a reduction in IL-6 in the endothelial cells. So there's now a study in cardiac transplant for using tocilizumab in a randomized controlled trial to reduce coronary artery vasculitis. This is underway. So again, looking at what we know about IL-6 induction, we know that with immune activation events, that IL-6 is very critical to stimulate T follicular cells, driving naive B cells to IL-6 producing plasmablasts onto plasma cells that make these pathogenic antibodies. And you can see that IL-6 also stimulates more terminal center formation when it's produced by these plasma cells, or plasmablasts, excuse me, and then also enriches memory B cells. What you can see here also is that IL-6 is upregulated in the endothelium. All this comes together to cause severe antibody rejection. Now, we first looked at a treatment starting around 2011 or 12 when tocilizumab was first approved in the United States. And we looked at patients who had antibody-mediated rejection, and that was chronic, associated with the type 2 or the de novo DSA and transplant glomerulopathy. What you can see here in these patients compared to standard of care, which is Retux, IVIG, and plasma exchange, that tocilizumab gave superior graft survival and also superior patient survival, because for the standard of care here, we find that we were losing patients back to dialysis, and this is associated with poor survival and higher death rates. Now, this paper is also important. This is a recent paper by Irish et al., and this paper really is a landmark paper. I don't know if many people know about it. It looks at changes in estimated GFR and risk for allograft failure in patients with late active antibody-mediated rejection. So what they did, they looked at about 91 patients who at 3 different centers, and looked at the course of these patients diagnosed with antibody rejection. You can see here, it looks like our standard of care treatment. These were not treated. So you get down to about 20% by 5 years. So these are death censored and overall graft survival. So what's important though is they looked at the trajectory of the EGFR, at mean EGFR at the beginning, about 0.757 cc's per month, decline at about 9 cc's per year. And you can see that the graft survival over 5 years is pretty bad. However, if you could predict that there was look at a drug that would give you a 30% improvement in slope, that you would have, you could calculate exactly what the benefits would be. So this is a decline, first 12 months. If you reduce it by 30%, you could see an improvement in EGFR would result in about a 10% improvement in death censored graft survival at 5 years. So these levels of improvement are very important. And this has now been accepted as the only, as a surrogate endpoint for the Imagine trial, which is now a labeling trial for an anti-IL-6 clazakizumab going forward. We looked at this in our own patients. You can see that with TOSI-treated patients in this group that we evaluated over 7 years, the decline was about 4 cc's per year, and it's 0.33 cc's per month. So it's quite different from no treatment. So we hope this will bear out in larger studies. Clazakizumab is an anti-IL-6 monoclonal. It is given sub-Q monthly, 1 cc. And this is the first study published looking at it in chronic antibody rejection. It's a very nice study in Jason, if you've not seen it. Basically, what the investigators found is that there were reductions in C4D and capillaritis. And then Dr. Halloran found that about 38% of patients treated, and this was a placebo trial, but treated, were found to have complete elimination of the AMR gene profiles. This was also associated with significant increase or stabilization, in EGFR over time compared to placebo group, which was declining. So the premise for this clinical trial is very much supported by this data. We also looked at this in an open label trial, same sort of thing, but we looked at it for longer periods of time. You can see here, we had a 24-month run-in, and this was a GFR at -24, and this is at time of treatment, already significantly lower. And for 2 years after, in these patients treated, you can see the GFR stabilized at both 12 and 24 months. This was we saw a decrease in IgG, and we also saw a trend towards increase in regulatory T cells. Now this is a paper, just briefly I want to go over, to show you a desensitization study we did where we used Plex, IVIG, and then clazakizumab monthly times 6 if patients were transplanted. And they received clazakizumab afterwards up to 2 years. So basically the results are here. First, this shows the changes in MFI for all antibodies. It's quite different than what you saw for the anti-CD20 obinutuzumab. We did see reductions in most patients from baseline for class 1 and class 2. You can see these as broke out by MFI strength. Even at the highest strength for both class 1 and 2, we could get reductions we think that would improve transplantation. And in fact, what we saw, that 20 of 20 patients were transplanted. More importantly, we saw declines in DSAs. These are one positive in transplant. You see at 1 year, we only had one patient that was still positive. This also, we saw very minimal inflammation of BAMF. And I think more importantly, what we saw is increases in regulatory T cells, both in and regulatory B cells and late times after treatment. So we think this may be a very important finding here in controlling inflammation in these patients. So let's just take a minute to this. We know if you look at the B cell, it may be a central player in this because B effector cells under stimulation are making IL-6 all over the place, stimulating Th17, making antibodies, stimulating macrophages. And so these are effector B cells. And these cells would tend to inhibit the regs, so you would still have Th1, Th17 activation and no Tregs. So if you add anti-IL-6 to this, we think that what happens here is you're deviating this back to a Treg and Treg profile. Thus, you would have inhibition of the Th117 and increased Tregs. So this may be a tip in the balance. So again, looking at how these drugs affect the pathways, we know we can inhibit germinal center activity with anti-IL-6. We can inhibit the activation of other cells by the IL-6 producing plasmablasts and reduce alloantibody production, and also reduce over here IL-6 expression in graft endothelium, resulting in a beneficial effect on the allograft. And this should result in less ABMR and long-term survival of these grafts. So I'm going to close here in the last few minutes to talk about a new diet, but focusing on Igg recycling. This man is a very important and very interesting man to me. He is F.W.R. Bramble, 1901-1970. And he wrote this paper back in 1955 on the route by which passive immunity is transmitted from mother to fetus in a rat. And what he did, he showed that rabbit antibodies could be detected in the circulation of fetal rats. However, if you cut the FC end off of it, you didn't see it anymore. So he didn't know really what was going on, but after his death, this receptor was discovered. It's called the FC neonatal receptor. And this is a very interesting pathway because it is now known that it is present not just in neonates, but it is present in every cell in our body, mostly endothelium and macrophages. And Igg molecules, these very precious antibodies, are recycled, going into a pH-dependent recycling pathway. So at pH 7.4, they're endocytosed into a vesicle. They become protonated with hydrogen ion at pH 6.5, and they bind to this FcRn. And if they're bound, they're recirculated, sort of buffed up, and go back to the circulation. If not, they're degraded. So if you knock out the FcRn, you get a half-life of Igg going from 30 days to about 2 days. And so IVIG is also important here, our old friend, because it saturates the FcRn and allows the degradation of the pathogenic antibodies, and while allowing the administered Igg to circulate and protect the infection. So what we know now is that this has been harnessed, and there is a drug, first drug approved for, it's called Vipigart. There's an FC portion that blocks FcRn recycling, and it's effective in treating myasthenia gravis. So we'd like to see this more in our transplant patients for and desensitization. And then just briefly a word here too, because you can see here, this is all, and for all of us who are interested in antibody engineering, that one of the problems with current antibodies, say IL-6 or eculizumab especially, is they can bind the ligand, they get recycled, and they go back out with ligand in hand. So you have to get more and more antibodies. And what has been done is that these companies have enhanced FcRn binding of these antibodies so they're preferentially recycled. But at pH 6.5, the ligand is released and degraded. And so the antibodies are shot out, renewed, and able to just sort of shuttle the target back into the endothelium. So the endothelium here is clearing the target, and also allows you to use much less antibody, and you have longer times between administrations. So this is a big advance for all of us. So emerging therapies for 2022, I think, and hopefully beyond, imlifidase is already approved in the European Union by for treatment of desensitization. Every country in the EU can now use it, and it's being studied by Hansa Pharma. Anti-IL-6 imlifidase, or excuse me, anti-IL-6 clazakizumab in combination with Plex IVIG can lower antibodies. There's also a very important study for desensitization, for treatment of antibody rejection called the IMAGINE study. There's now 105 centers worldwide in that. I didn't talk about anti-CD38 or anti-BCMA, B-cell maturation antigen. Daratumumab and beltacept are also being studied as germinal center and plasma cell inhibitors. And then I think the FcRn blockers are going to be very important as well. So, and I think persistence and patience for a better world is very important here. And throughout my career in medicine, I can truly say that the most important thing that we can give our patients is hope. There are many problems that are beyond the resolution of medicine, but we must never give up our efforts to restore them to health and happiness and for them and their families. And I really appreciate your attention today. Thank you.
So Dr. Jordan is not in an area that you can log in today to answer questions. That means we have more time for our last speaker today.